benzodiazepines and prescription opioids. Thank you for that reminder. Cocaine and ecstasy. Non-medical use of pharmaceuticals actually is on the decline. Between 2016 and 2019 it did. In part, that was because there was a significant difference from 2016 to 2019 in that over-the-counter codeine was no longer made available. You'll recall also in 2018 that codeine became a Schedule 4 medication, and that's accounted for as a significant difference in the acknowledgement of prescription pharmaceutical opioid misuse in Australia. So there's been a reduction in prescription opioid misuse, but I put this in the context of here, these are the latest figures, and I'll guide you to the right-hand side. I think we do have a... It's not working. The point of showing you this is there's been cannabis has increased, cocaine's increased, ecstasy has increased, hallucinogens. Essentially, the use of illicit substances are on the increase, which is another reason why it's particularly important to keep, I guess, an eye on illicit substance use, particularly in the context of prescription of opioid medications, benzodiazepines, antipsychotics, antidepressants, those sorts of things. So what's my role, or what is the role of an addiction doctor in the pain clinic? Essentially, it's consultation liaison. A large part of my job revolves around, as I mentioned before, the MDT meeting, where the more challenging consumers and patients of the service are discussed, spoken of, plans are made. It might be identified. I might be able to provide a little bit of insight into some of the features that are being discussed in these meetings. It's of interest to me that many of the complex and difficult patients that are discussed relates to mental health conditions, substance use conditions, and there's also a proportion that are straight up and up difficult to find their pain and treat their pain, but a lot of them have a psychosocial, mental health and substance use aspect to it. Of course, I do patient assessments, and part of my job is, and as I see it, to be an advocate for individuals. There can be a tendency when substance use is disclosed in a hospital setting for an individual to have the experience of, okay, I'm backing off, you don't get anything, I'm going to cut you off from medications, or we're not going to treat your pain because you've got an addiction problem. And so I see my role to some extent as to come in and bring in a voice of, well, that's one factor, but I don't think withdrawing treatment or withdrawing, pain management, for example, is the answer. I think there's a nuance, there's a middle ground, there's a safer way to provide treatment for this person, and that's where I might come in and offer some suggestions. I do a lot of discussion with the Department of Health and the Prescription Shopper Information Service to do some background information on this person. If there happens to be a person who is seeing greater than 6 doctors in a particular time period, or if they're using more than a particular number of identified medications, that's a flag that there's something seriously going on, and we can talk about it, and we can put in some safety barriers and mechanisms in order to make that person's access to treatment safer for them, and I guess maintain their contact and availability of medical services with their GP, and certainly with the hospital services. I do some time talking to the pharmacists. Pharmacists are a wealth of information from my experience. Here I'm talking about the community pharmacy. If a person is picking up their medication at a pharmacy in Willagee or what have you, it's very interesting to me what else they might be picking up. Occasionally I'll hear things that, yes, that person's picking up, diazepam from Dr. Smith, but they're also getting, a couple of other benzos from another doctor, or you get a bit of background information. It's very, very handy. And pharmacists are very useful in the plans that I make in terms of safer provision of medication. Couldn't do it without the pharmacist's participation. A lot of my discussions will be with the GP, discussing and supporting the GP. How can you make this better? What the conversations you have with people when it's talking about pain and dependence and pain and substance use. These are tricky conversations. It's not an easy thing to raise a topic with a person. For example, the topic of introducing urine testing into the treatment modality. Bit of a difficult conversation. I try to talk about it as a normalisation, and we're doing this more. It's recognised that people have problems. This is as much to give me confidence that I'm doing the right thing in your best interest, and we're keeping everything safe. Those sorts of conversations, very much what I have with GPs. A large part of the information I give to the team is my risk assessment. Does this person have a history of substance use disorder? Is the alcohol use one that is likely to cause significant problems with the medications that you're prescribing? How are we going to do this better? Are we going to begin stage supply? Are we going to limit it to a pharmacy? Are we going to talk to the GP? Those sorts of things. Is the person CPOP suitable? From time to time, a person that I come across in the pain clinic, I will refer to Next Step or one of the CADs for an assessment of whether they would be better served and more safely served by moving from pain management into pharmacotherapy. That can also happen in the opposite direction. So I'd refer them to the CADs. And a large part is education, something that I'd like to do more of. I can see Mary smiling there. I'll definitely get into that at some stage. So I really do think I've got a role to educate, that sort of mentor role, corridor consultations. It's really something that I really appreciate, talking to the pain fellows, having a little bit to do with their education, usually just before their exams. So that's a joy in the work as well. The workforce development role, I'm particularly interested in workforce development not only in the pain clinic but in the broader medical fraternity in Western Australia. It's something we've got some plans for at Next Step. So it's talking to the nursing staff, talking to the fellows, talking to the consultants, but also talking to the family, talking to the carers. I'm a little bit of a go-between to some extent. It's not uncommon for a person to get referred to Richard O'Regan, and they come along and they think it's Richard O'Regan, pain specialist, who's going to help them with their medication or provide some sort of intervention, which always makes me smile on the inside, but cringe a little bit because I have to say, well, actually, no, I'm the addiction doctor, and there was an identified issue here, and we're trying to be safer the way we go forward these days. Usually I can swing it around and generally get to a state where we have a pretty good conversation, and it's usually beneficial. I like to think it's beneficial for the individual. This gentleman here, 46-year-old male who's been treated with Ficeptone for a number of years. The pain specialist advice 3 years ago was to reduce and cease the opioid, feeling that this person had been on Ficeptone for a number of years, and it was probably a time to reduce and stop that use. This gentleman had a past history of IV heroin use and had been on OST, opioid substitution treatment, in another state. The issue at hand had been a motor vehicle accident. He sustained a head injury. Part of that resulted in some disinhibited behaviours. He had been prescribed oxycodone in the past, and as is often the case with a person who's referred to me, a self-escalation and increase of use of the oxycodone, and potentially things like lost script or going to several doctors to get access to oxycodone ensued. Part of the problem with his head injury had been disinhibited behaviour resulting in aggression, particularly at the pharmacy. So the end result was that he had a carer. He was not permitted to know where his pharmacy was because there was too many arguments and disagreements and aggression, essentially. So the question was he suitable for OST? We talked about it. We talked about the options. We talked about reduction and deprescribing of Ficeptone. This particular case ended up with a referral to the CADS for suitability and discussion with regard to Suboxone. That case led to a conclusion that OST probably wasn't actually in this person's future, generally because of the difficulty of daily dispensing and attendance at a pharmacy. And if you've got somebody who's not suitable to go to a pharmacy for daily dispensing, that really rules out something like pharmacotherapy. We haven't actually come to the conclusion of this fellow's treatment yet. He's still on Ficeptone, and it's an ongoing discussion, and it will probably lead to some counselling and guidance and support for him and his GP, new GP, in terms of a reduction of Ficeptone over a period of time. I'm providing support to the GP, and I guess I'm a liaison between the GP and the pain department, and to some extent the doctor who saw him at Next Step. Another case, a 51-year-old female with a past history of methadone maintenance treatment back in the 90s, diagnosis of pancreatitis, an ongoing episodic severe pain condition. Problem was, with the use of oxycodone, as is not uncommon, a little bit of overuse and extra use, recurrent presentations to the emergency departments, seeking additional medications, use of non-prescribed opioid medications, benzodiazepines, smoking a large amount of cannabis, an admission earlier this year to Fiona Stanley Hospital in the context of her prescription opioid use, significantly high level of alcohol use, and at the time what was thought to be self-harm, potentially a suicide attempt, which frequently when you talk to somebody some weeks or months after the event, the intent often it changes, and perhaps it wasn't that. It was more a situation of sadness, looking for some relief, not necessarily to die. So again, we had a long discussion, clarified the options for her, which would be included pharmacotherapy. I had some discussions with her GP, with her chemist. Spoke with the Department of Health, prescription shopping information, and of course the pain team. The outcome of this particular one was a negotiation towards the continuation of pain medications, in this particular person's case, tapentadol, some advice on strict prescribing and stage supply of the benzodiazepines with the GP. I'll generally say, look, we've got to start bringing that down. You certainly don't want to increase it, and in this particular person's case it was about stage supply. I can't recall, it might have been something like twice a week, once a week supply of medications. Occasionally I'll make a recommendation of this person really needs to pick up their medication on a daily basis, similar to Suboxone or methadone. And there was also a referral to the CADS in relation to cannabis and nicotine replacement therapy. It's interesting, I spend a lot of my time talking about nicotine replacement or smoking cessation, and I find there's quite a lot to talk about and to support people, and also the GP, and I prescribe nicotine replacement on a fairly regular basis as well. Last case study, 67-year-old female, widespread chronic pain basically everywhere, was treated with tapentadol and pregabalin, tricyclic antidepressants, and most of a bottle of alcohol, most of a bottle of wine, 4 to 5 times a week. She'd been doing that for 40 years. The issue was increasing pain, memory impairment, and a recent fall requiring an ED admission. Again, the sorts of things that my role here would be to have a good conversation with her about what she's using the alcohol for, clarify the issues, the concerns that her prescribers and I share, and her GP, with regard to her alcohol use, put that into perspective that she can understand, give her some information, talk to her GP. We would talk about a home-based alcohol withdrawal. Probably I would start in a lot of situations looking at the Drug and Alcohol Withdrawal Network, DAWN, and that would depend on whether she's suitable, and they particularly would need somebody who's, they've got a suitability criteria. If I found that a person who's looking for a detoxification is not suitable for home base with the support of DAWN, I'd be looking, of course, to a referral to the inpatient withdrawal unit. And finally, talking about anti-craving therapy, I do a lot of that. still surprised me that this day and age, a lot of doctors, a lot of GPs are less familiar with things like naltrexone for alcohol dependence and acamprosate, the anti-craving medication. So I do tend to talk to them, educate the patient and the GP along those lines. What do I see as the future? Potentially, I think there's going to be impact on WA potentially as soon as December this year, when real-time prescription medication monitoring comes into Western Australia. As you would be aware, it's been in Tasmania for well over 10 years. It's been in Victoria now for 2 years. And we are looking to roll that out in Western Australia, I understand, later this year, early next year. My anticipation is that's going to identify a number of people who are accessing pharmaceutical medications, and I really do think that pain clinics are going to be inundated with a number of people who've been identified with that. GPs are going to say, I'm not quite so sure about this, or I'm not sure that I can do this unless I get pain clinic or pain specialist imprint on that, and I think that's going to cause a lot of work for people in pain in Western Australia. Potentially there may be addiction specialists on other pain teams around WA. I think that would be a useful thing for the sector to grow and nurture and develop, and potentially it will be pain team role will be the role of an addiction doctor within a hospital. We haven't actually got that in Western Australia. It's quite common in the eastern states, but there are moves afoot, and there's some advocacy going on towards that. Potentially in the near future, we might see that in WA hospitals. Thank you very much. Are there any queries or questions about my role? Yes. Hi, Pete.
Either of those three cases health department notified?
Well, yes, I get information from the health department pretty much on everybody. So I might get referred somebody, and that's where I actually start.
And with those three cases you just presented, will the health department notified they registered that?
No. No. The second case was on the register of addiction. However, if you're on the RDA and you're in a pain clinic, you can still have your tapentadol or what have you, so long as the pain clinic supportive of it. And sometimes I suppose my support for that is useful as well. For the person who is using alcohol, no. And for the first case, he's not on our register. No, he wasn't. And although they know about him, at the moment, the view of him is that he's really in pain. So no, he wasn't, and they don't have an issue at this stage with him actually getting that. He doesn't have to go on to pharmacotherapy.
That's being notified advising us on pharmacotherapy, pain approval to keep managing. Given we've heard that prescribed opiate and magnesium combined with Xeric and benzoyl, so people are more risky than heroin. Why are they continuing to be treated?
Hang on, sorry, I'm not sure.
Why are they continuing to be treated?
But they're not. That's the whole thing. You don't. When you say notified as an addicted individual, you can fill in that form, I suppose. But none of those people had that effect, and the person who was on the register there was no real concern about that person continuing to get treatment with the pain clinic. So there is I guess if there's a person who's on the register can still get treatment if there's support for it in the specialty fields, and it could be a rheumatologist and that sort of thing. Not quite sure if that answers it, but there's no conflict.
Is the patient's consent required to notify them?
Absolutely not, no. We're actually obliged to do that, and I will have a conversation with health, so but there is a little bit of wriggle room, as I see it. Yep. Absolutely, yes. Yep. The person who was a ex-user 12 years ago, if they have had no contact with prescribing of opioids, so S8 medications, the health department now actually expunges them and takes them off the list themselves. And that's been happening now for, don't quote me, maybe 6, 7, 8 years. But as everything in the world, it's not perfect, and there are some people that haven't been taken off the list, and I don't know why that's the case. But yes, a person can. If a person's been on the register and they are receiving Schedule 8 medications, they won't get their name taken off the register. The health department they just won't do it. But under those circumstances, that person with the support, and that's where potentially I could come in at Charles Gardner Hospital, and sometimes at Next Step we get people coming to Next Step for an assessment, and I can recall doing it myself, and as many would go away and maintain their medication even though there was a substance use issue going on. But if the discussion was, look, I actually think this person should stay on prescription opioids with some safety checks and balances, which this is what I'm recommending, and almost universally the health department will write to the prescriber and say, here's a report from the pain person, here's a report from the addiction doctor, and the conditions that you continue to prescribe are daily dispensing, single pharmacy, pain treatment agreement, don't go above 80 milligrams oxycodone a day, etc., etc. So I've seen a lot of situations where that can happen, and I think it comes down to potentially the right people in the right spot and the right advocacy at the time. Right. Who wants more? Oh, Amanda.
With your case one, when you get considering OSP, but there's a problem with daily dispensing,
potentially you do have to get onto Suboxone to begin with that, and so that would have still been a difficulty of getting that person daily dispensed. It was an option, but really, in my belief, that person, the option now is really going to be coming off Phyceptone, and that, I suppose we will try that, but right now that wasn't the preferred option, if you like. It's a potential, though.
The other is what I've noticed with the last with yours and Renee's is that the mental health aspect of substance abuse just is absent pretty much apart from the comments I do, because clearly, particularly with opiates treat psychological as well as physical pain, and so there it's often used to soothe the traumatised, the hungry guys that were in that case with about addiction. But the addiction services and mental health remain siloed. Is Next Step looking at that? Because I think if you're trying to treat addiction in the absence of having some help for the underlying motivation for it and the damage that has led to it, seems...
Well, for example, the pain team that I work in has a psychiatrist. So there is that. So that aspect within the pain multidisciplinary team is certainly there.
In substance use, generally, which is not pain.
We don't have entwined services yet, and I think people have been aware of that, and that's been something that we've worked towards to some extent. Yes, Mike? Oh, sure, yeah.
So yes, there is some, but the problem is that most of the things is people come using opiates and they're not able to get them because they then go to things like gabapentin, to benzodiazepines, etc., to numb themselves. So they're all joined and put together. The mental health aspect of people who have childhood sexual abuse, etc., who are using medications in order to be able to survive. Yes, but there doesn't seem to be any, in fact, the problem is ping pong, which is that AOD won't treat people with psychiatric or significant ones, and mental health won't treat people with substance abuse.
Well, it's not. I mean, it's not always. It's not complete. Obviously, nothing is complete in the world. But I agree the motion towards having AOD embedded in mental health and vice versa. It's not a new concept. We have had that with the InReach service up at Joondalup that started some years ago. Again, hit and miss, but certainly something we have to do.